Hi, everyone. My name is Rai Gao. I'm a current second year at Hopkins. And today I'll be speaking to you about my project, which is the feasibility of an adapted weight loss, a behavioral weight loss intervention for individuals with serious mental illness in the community. So we can advance to the next slide. Okay, great. So as some background, individuals with serious mental illness or SMIs are significantly more likely to have overweight and obesity and the corresponding health conditions. So one recent North American study found that nearly 80% of a sample of over 10,000 people with diagnoses of schizophrenia, bipolar disorder, or depression to be overweight or obese. And weight loss amongst individuals with SMI present really unique challenges, particularly related to the cognitive impairments in this population, which require specifically tailored interventions. So one program that I tried to address this was the Achieving Healthy Lifestyles in Psychiatric Rehabilitation, or ACHIEVE trial. And this demonstrated significant weight loss among persons with SMI at 18 months, which was the first study to do this. And it was an RCT that tested an intervention that consisted of weekly group weight management classes, individual appointments, group exercise classes, weekly weigh-ins, and it was specifically designed to address the neurocognitive deficits in working memory, verbal memory, and executive function that are really common for people with SMIs. And given the really high prevalence of obesity in the SMI population, it's a really critical need to adapt this ACHIEVE program for delivery within community mental health center staff. And then this program is actually called ACHIEVE D, with D standing for dissemination. So the primary study objectives for this project were to determine the feasibility of delivering the Achieve D program in a community mental health setting, and to determine the acceptability of the program to participants with SMIs. So next slide, please. Great. So moving into methods. So this study design was a proof of concept study. It was a prospective single arm study at one site. And it was at a specific community-based a psychiatric rehabilitation program in Baltimore. And it was piloted for 17 participants with SMI who were recruited from the facility. So one of the health coaches from the study team delivered 8 weeks of the 6-month total curriculum to participants, and included group exercise, weigh-in, weight management, instruction, and goal setting. And out of the total 6 months, 2 months of material were delivered, and with one of the months being weight loss success and the other being sugar sweetened beverages. So the primary outcomes of the study were to look at attendance, and this was logged for each session, the coach's overall fidelity to the curriculum. So each class was video recorded, and then these video recordings were graded for fidelity using a standardized tool developed from the original study. And then satisfaction was gauged using focus groups that were conducted with participants at the end of the program to determine its acceptability. And then for the data analysis, a mixed methods approach was used. So there were descriptive analyses in regards to statistics for all the data, and then also the video grading data. And then an editing analysis style technique was used for the transcripts for the focus groups. Feel free to advance to the next slide. Great. So moving into the results, overall, the participants were 47% women, 47% white, and had a mean baseline weight of 109 kilograms. The average attendance was around 71%, meaning that the average participant attended 71% of classes, and every class had around 7 to 13 participants. And then fidelity to the Achieve D curriculum was actually pretty high for most scored elements. And the instructor was able to meet or exceed expectations for over 75% of classes in 21 out of 30 total criteria. And out of those remaining 9 criteria, about 4 of them are related to time management. And with the only section not having issues with time management being the exercise portion, which was video led, so that was less concern. And 2 primary points that were not consistently addressed included offering encouragements to participants that they'll be successful when they follow the program, and inviting participants to identify how and when they'll try out the program and their plans. And these have been shown to be really critical in maintaining adherence to the program and their high weight goals. And then during the focus group, participants stated that the program increased their weight loss knowledge overall, promoted health behavior change, and built their confidence to be more physically active through the group exercise sessions. So overall, 88% of participants stated that they would want to continue with the program, and 94 would recommend the program to potential program participants. Next slide, please. Great. So there were a few limitations. So we had some technical issues with video recording, and that resulted in only partial segments for some sessions. So to address this, we just graded all the fully recorded sessions only. And then inherently due to the study design, it had a small sample size and was only conducted at one site. So in conclusion, Achieve-D was feasible within the community mental health program setting and generally acceptable to participants with SMI. And this can be seen through the consistently high attendance at these sessions and overall high satisfaction with the program for participants. And the coach also had high fidelity to the Achieve program curriculum. And all this is really promising given that individuals with SMI have a lot of competing priorities, and it's really promising that they can be engaged in such an intensive program. So further modifications will be made to the curriculum to address the primary challenges in time management, and primarily in preparation for the next step, which is training a mental health program staff in the community to deliver this curriculum in a pilot study with multiple settings. So great, thank you all for your time, and please let me know if you have any questions.
Fantastic. By the way, yes, we want to open it up for questions from the group. Fantastic presentation. Very exciting work in a very much needed patient population. So thank you for showing and sharing this. And this was in Baltimore, I imagine, right? This was a Baltimore site. I was curious, where was the site at? Where was this localized at?
It was relatively close to campus. I wasn't given the exact name of the PRP or the psychiatric rehabilitation site. I'm not sure if that was due to like privacy concerns or something, but all the data I analyzed was de-identified.
And were the coaches, they had to go through a specific training to be able to be a coach for this?
Yeah, so I think for this study, they used a coach from the original study team who is already trained. So I think the primary variable that we're trying to look into next time is whether or not the leader's guide alone and maybe more less specific training, less intensive training of the community mental health program staff members who are already on site is going to be as successful.
What's the kind of uptick to get people trained? What's the time requirement and how long does it take typically?
Yeah, so I think it's about like a 2-day training, but I think they're still working out the kinks because the program itself seems that the leader's guide isn't always clear in a lot of areas, and that a lot of this project sort of elucidated that. So trying to refine the leader's guide and find the best way to deliver it, so that it isn't too much of a burden upon the staff as well.
Right. Very nice. Very nice. Anybody else have questions that we'd like to ask before we go in? Excellent. Thank you very much. Outstanding job. Really appreciate it. All right. Good. We're going to go on now. Forgive me as I try to change to the next. So let's go with Thomas Gracie. Is that all right?
Yeah, sure is. Hi, pleasure to meet everybody. Just by way of introduction, my name is Tom Gracie. I'm a fourth year student, just finished interviewing for internal medicine, so I will be joining the ranks.
Oh, fantastic.
All right. And just let me know whenever we're ready to get started. So I'll just go ahead and get started if that's okay with everybody. So like I said, my name is Thomas Gracie, and today I'd like to share with you guys today a meta-analysis and systematic review my colleagues and I wrote on the association of preoperative frailty and postoperative delirium. So I would actually like to begin today's discussion with postoperative delirium. So in brief, patients who develop delirium after surgery carry an independent risk of morbidity and mortality compared to their peers who do not. Specifically, in addition to having higher mortality overall for a variety of reasons, these patients have longer inpatient stays and up to a year after surgery have higher rates of persistent cognitive decline. So the question is, how can we identify ways to predict which patients will become delirious after surgery? And one very promising metric we have is frailty assessment. And this is particularly important in patients that are over 65, as between 4 and 17% of patients over age 65 are phenotypically frail. And a lot of work has been done in this area. Problematically, however, there's a duplication crisis. In other words, there are so many frailty tools out there, and only a handful of them have actually been validated by use in the clinical setting or by other research. Another problem is a lot of these tools are based on chart review and are not bedside assessment tools, which decreases their validity. Finally, many frailty assessment tools are simply impractical for high-paced settings such as the anesthesiologist's office or a primary care setting for pre-op assessment. So our goal for this meta-analysis is to look at the field of literature and pare it down to a subset of studies which use validated frailty and delirium assessment tools in surgery that can be used in a fast-paced setting to accurately predict the odds of developing postoperative delirium in these frail patients to allow for better shared decision-making before surgery. So let's talk about some of the inclusion and exclusion criteria we use to make this happen. So I'll go ahead and advance the next slide, please. So this is our Prisma diagram showing the studies that we worked through to create our high quality subset. So if you look over on the right-hand side, the main reasons why we excluded studies at either the abstract screening or full text screening stage, besides not being relevant to the study question, is for invalid frailty assessment. Again, using a tool that has not been validated or is based on chart review. And other reasons we encountered were similar problems for delirium assessment. Other inclusion and X criteria that were very important were excluding patient populations that have their own risk of delirium having nothing to do with frailty. So for example, neurosurgery patients, patients with history of stroke, patients who are receiving emergent surgery. The reason why is a lot of these are trauma patients that have a high burden of illness that could be multi-system, having nothing to do with the surgical problem, could also affect delirium. We also excluded patients with substance use disorders. As you can imagine, these can predict postoperative delirium having nothing to do with the surgery or frailty. So now let's talk about the 9 studies that we pared down to that met all of these inclusion and exclusion criteria. And we'll go ahead and advance the next slide, please. So these are the 9 studies we pared down to. And I just want to talk a little bit about what kinds of surgery are being done so that when we talk about our findings, you know who these findings apply to. So of our 9 studies, 6 of them were what we would call high AHA cardiac risk. So what that means is that these procedures have been shown to have the highest risk for MI, which is the most feared complication of surgery. And it's a pretty good surrogate for the burden of illness that surgery provides. So almost categorically, these are cardiac or cardiovascular procedures. However, 3 of our 9 studies were intermediate risk surgeries. So classically, like your general abdominal surgery, your arthroplasties, spine procedures, and urologic procedures. So now that we know what sort of patient population we're talking about and the types of tools that were used to assess them, let's talk about what we found. So we'll go ahead and move to the next slide, please. So this is our summary plot for the estimated odds ratio for delirium in frail patients. As you can see, over our pool of 794 patients across these 9 studies, we found a summary odds ratio of 2.1-fold higher risk of developing postoperative delirium in patients that are frail. And as you can see on the right, that confidence interval does not encompass 1. So this is, by our account, a significant finding. So this is very important because this demonstrates the need for talking about the risk of postoperative delirium when we're counseling patients before surgery, because again, we know that postoperative delirium carries its own morbidity and mortality. So addressing that up front, if it's a non-life-saving procedure, so something strictly elective like a hernia repair or maybe an arthroplasty, it may even be part of the shared decision-making that surgery may not be the best fit for this patient. Or if it is a life-saving procedure that needs to happen, this can allow us to predict who needs more resources for the allocation of delirium prevention. And we'll go to the last slide, please. All right, so this data need to be taken with a grain of salt for several reasons. The first reason is you cannot randomize frailty phenotype. So all of the studies we're doing are observational studies in patients that have frailty. So that's one source of bias that can affect the outcome. The other thing that's important to note is that there's also a considerable amount of bias within the studies. So we use the Robbins Eye assessment tool, which is how you assess bias in a non-randomized study. And what we found is most of our studies were at moderate or serious risk for bias. The main reasons were because of confounding variables at baseline, like cognitive impairment at baseline and different age between groups, how the participants were selected from retrospective trials introduced bias, and also how
Time.
things were measured as well. So thanks for having me at the conference, and I'm happy to take questions at this point.
Excellent. Thomas, thank you. Yeah, great topic. Very, yeah. I'll open up for anybody have questions, and then I got plenty. If anybody has questions, please. Thomas, I'm gonna go first. It's a great topic. I'm a primary care doctor. I do pre-ops all the time. We tend to use the ACS NSQIP risk score calculator to help risk stratify patients, and they added a frailty index to it. These studies that you looked at, what was the scoring system for frailty? How did they determine the patient's frailty? It seemed there was a mix of studies there.
Right. It's a deep question because there's so many ways of measuring frailty. Some tools are phenotypic, like your Fried frailty scale, that's based on poor grip strength, poor timed up and go. And then you have these we call them frailty indices, which are basically adding up all the patient's disease states. We call that an index. Most of these were based on phenotype. So Fried or a variant of Fried, which is really nice because those can be assessed relatively quickly. Barring, of course, chart review tools that can pull all those comorbidities together.
Gotcha. And as you kind of alluded to here with this, I think there is a lot of heterogeneity, I imagine, between these studies.
Yes. We found that the age between studies could vary. So some of them are your oldest old, like 80 to 90. Others were your sort of 65 to 70. And the other place we saw heterogeneity is some frailty tools actually measure cognition and some don't. So as you can imagine, if you're trying to predict delirium, you can see an effect there. So that's a future direction, trying to substratify, once we have enough studies, tools that are cognition blind versus those that are not, to see if they're predictive.
Right. So what's the next step here? What do you think? This is a great topic. Where do you go to next?
Sure. So the next thing is just to wait for more literature. And the reason why is, again, we would like to do a subset analysis of either cognition blind tools to see if somebody who's cognitively 30 out of 30 mini mental, who's phenotypically frail, has the outcome. The other thing we would like to do is a subset analysis of just studies with high quality. As you can see, many of these had serious bias. We would love to see a repeat analysis that's much cleaner. And then the last future direction, I left out entirely the discussion of people who are pre-frail, so they're intermediate. We did an exploratory analysis on them that was inconclusive. So once we have more studies, we can say, does pre-frailty confer a risk as well?
Very nice. Very important topic. Excellent. Thank you. Great. I think we'll move on in the interest of time. Okay. Oops. Let's see. All right. Let's go. Shujan? There he is.
Yeah, sounds good.
Excellent. Let me bring up your presentation here.
All right. Well, good morning, everyone. I'm Srujan Kvarapu. I'm a third year at Hopkins, and our project looked at radiation exposure during vertebroplasty and kyphoplasty. Next slide, please. So percutaneous vertebroplasty, abbreviated PV, and balloon kyphoplasty, or BK, are two minimally invasive procedures used for pain relief for vertebral compression fractures. They involve cement injection into the affected vertebral body to improve its support. PV directly injects the cement, while BK inserts and inflates a balloon first to stent open the space and provide more room for the cement. Now, this is performed under image guidance via fluoroscopy. As such, radiation exposure is a concern. However, that exposure is very poorly characterized in the literature, and for two reasons: significant data heterogeneity and a lack of standardization of values, something we addressed in our methods. Our objective was to review the available literature to clarify what the true exposure might be. So what did we do? We queried 5 databases using the Covidence platform to organize the review via Prisma guidelines. Over on the figure on the right, we started with 1,600 records, removed duplicates, and screened abstracts for relevance. 80 full texts were reviewed with exclusion criteria down here in the bottom right, and 27 studies were finally included. Exposure estimates were provided via radiation dosimeters placed on the operator or patient, and there were 3 main ways that we standardized the values to allow for comparisons. The first way is that we standardized values by the number of vertebrae treated. The second way is that all dose estimates were converted to millirems. In the literature, the units are all sorts of things like rems, sieverts, grays, so we put them all into millirems. And then the third way is that numbers needed to harm, abbreviated NNH, were calculated via annual occupational dose limits per organ given by 2 regulatory commissions, the USNRC and the ICRP. Next slide, please. So these are the results for operator exposure. All 4 tables are organized similarly and are stratified by the usage of protective equipment or not. Radiation protection measures may have included lead-lined goggles, a thyroid shield, a lead apron, or lead-lined gloves. We looked at the time it took to do the procedure overall, the fluoroscopy time, and radiation doses measured at the eye, neck, torso, and hand were available with their corresponding NNHs besides them. Now, there are a lot of numbers here, and we ran a bunch of statistics comparing between and among all these groups, which I'll show in a couple slides. But I wanted to point out a key finding here in the protected conditions at the bottom. If you look at the NNH estimate for the hand, for PV, it's 524, and for BK, it's 266. And that is the lowest NNH across the body locations that we looked at. In other words, that means that the hand exposure is the limiting factor in terms of reaching that annual safe radiation dose limit. Next slide, please. So here are the results for patient exposure. Radiation exposure was recorded in 4 different ways, some as direct measurements, such as a dosimeter placed on the patient's flank or an entrance skin dose. And there were indirect measurements, such as a dose area product or an effective dose calculated from the fluoroscopy settings. For 3 of these measurements, including both of the direct measurements, PV had lower exposure. However, BK actually had lower exposure by a calculated effective dose. This makes drawing an overall conclusion in terms of PV versus BK for patient exposure a little bit tougher, but given that both of the direct measurements point towards PV having lower exposure, and this is consistent with the operator exposure, as I'll show on the next slide, it seems most consistent that PV does have lower exposure for patients. Next slide, please. So here are the comparative statistics, all performed via independent samples t-tests. Protection decreased exposure for both procedures. This was sort of a sanity check in terms of seeing if this heterogeneous data has validity, and it did decrease exposures. That's great. PV had lower exposure than BK in both the unprotected as well as the protected conditions. And PV also had shorter procedure and fluoroscopy time, which can partially explain the lower exposure. BK is a little more complicated of a procedure. It takes a little more time to inflate that balloon, so it explains a little bit of the extra fluoroscopy time that we see there. And then for patient exposure, although the results were a little contingent on the means of assessment, it seems in general that PV had lower exposure than BK. So what does all this mean? Radiation protection is effective for these procedures, so we can continue to recommend those appropriate protective measures. BK has greater operator exposure, and this effect persists even with the use of protective equipment. And BK may also result in greater patient exposure. So a combination of these factors may help influence the decision to perform PV versus BK. Fortunately, the NNH for these procedures is relatively high at 524 and 266 for PV and BK. And really only busy proceduralists might hit these numbers, though proceduralists who perform a bunch of other procedures with radiation exposure might be at a cumulative risk of hitting those limits as well. So overall, we hope that our project helps interventionalists be a little more cognizant about radiation exposure, helping them make decisions between using PV versus BK, using intermittent or pulsed fluoroscopy instead of continuous fluoroscopy, or even adapting to the usage of newer technologies with possibly lower radiation exposure. There are a lot of things on the horizon like augmented reality, laser navigation, computer navigation, or even CT guidance, which is becoming increasingly common. These newer modalities might lower radiation exposure, and that's actually a future direction for us, is to compare the newer modalities to conventional fluoroscopy. All right, thank you very much.
All right, Sujan, thank you. That was really cool study. I guess you're interested in radiology, maybe in the future career path. Interesting. So, what is the typical time for a PV or BK procedure? You mentioned that certainly BK. I understand that's more complex. What is the time for these procedures typically?
So, if we go back a couple slides here, so the procedure time seems to be about, if we look at say without protective equipment, about 30-ish minutes for both of them.
Yeah, looks like there is definitely variation, isn't there?
Yeah, and one thing about that is because the procedures are so short, an interventionalist might have a bunch of these procedures in a single day. So, that can really impact the total number of procedures that you might do, and you might actually hit that annual dose limit because of that.
Yeah, very cool, very well done. Very, very systematic, and we always like when we have talk about number needed to harm, and agree that seems to be high numbers. That I don't know if an average proceduralist would hit these numbers, depending on their volume, I guess. And I know these were in vogue for a while. They got popular. Some negative studies came out, and then, but turns around in my clinical practice, I've seen it being very helpful. And I think they're back in vogue again. I think picking the right patient is the key with these procedures.
I'm a hospitalist, and we use them all the time. I mean, when we have patients that come in, in significant pain, it's sometimes the only thing that we can do to help them. Yeah,
you heard these stories about people walking off the tables, right? Which it's pretty amazing. And whether PV or BK, which one's the preferred procedure? I guess that's I know there's always a little subjectivity, I guess, which route to go on this. But no, it's a great thing to think about, because we don't always think about this, certainly as internists, about radiation exposure. And it's great. And I guess that if you're going to get radiation exposure to hand, makes sense why that would be. I guess it's in the field most commonly. Do they have special gloves or anything for proceduralists? I imagine this is not the only procedure that involves this type of exposure to hands.
Yeah, there are like lead-lined gloves that you can use. I'm not entirely sure how commonly they're used. From my experience with fluoroscopic, I guess like shadowing a fluoroscopic procedure, they may or may not be used. So, that's one thing that our study could help to make sure that more of those gloves are used.
Yeah, I guess an education that people should wear their gloves. Yeah, I imagine, well, depends on how heavy they are, how easy they are to manipulate. Very nice, very nice. Well, do we ever get Wiesma? Did she ever come on? I don't think so. Don't see that she ever did.
Doesn't look like it.
All right. Well, it's unfortunate, because it was a very interesting study looking at predictors of COVID-19 outpatients and what predicts hospitalization and bad outcomes in outpatients COVID-19. I thought it was really a neat study. And in the end, I'll just share with you, I think it was kind of interesting that it was the pulse oximeter that seemed to be the most predictive in that particular study she did. So I think that was within, obviously very pertinent study for what we're currently dealing with.
Okay, so good morning, everyone. My name is Vivian Kalu, and in the next 5 to 6 minutes, my goal really is to, tell you a story that answers why this research, how did we do it, what did we find, and what next. Next slide, please. Thank you. As you can see from the pie chart on the right, 63% of the US female population are whites, while 13% are Blacks. But on the pie chart on the left, there seems to be a discrepancy. Now, Black women in the United States are disproportionately affected by HIV. And the CDC even finds that they comprised, I think, about 58% of the new diagnoses among women living with HIV in 2018. So it's what happened? right? While older Black women face more compelling health needs and comorbidities than their younger counterparts, in addition to several other social determinants of health, which may prevent their timely initiation of antiretroviral therapy. And you may be wondering, well, what determinants of health? I had the same question, right? And this actually led to the goal of this research, which was to investigate and explore the effects of familial relationships on health outcomes of older Black women living with HIV in Miami. So that's why. Now, what did we do? First, IRB approval was obtained and 17 participants were recruited at an ambulatory care center in South Florida using an inclusion criteria. A questionnaire was used to conduct audio recorded interviews, which were transcribed verbatim and analyzed using directed content analysis approach, which we built themes, data themes and codes off of, right? And I'm gonna be discussing these in the upcoming slides. So what did we find? Next slide, please. Examples of data themes were support from family and the effects of HIV status disclosure, caregiving roles as extrinsic motivation, and being in seroconcordant intimate relationships. In disclosing their HIV status, some women experience a stronger bond and thus more support from their families and friends, while some others recounted instances of discrimination and rejection from their families, which actually drove them to unfavorable living conditions on the street that deterred treatment engagement. Next slide, please. On one hand, caregiving roles can be burdensome and conflict with medical appointment adherence. And then on the other hand, some women experience that it served as motivation to seek care. And they stated the importance of being healthy enough to actually care for their families. One other thing to note was that managing household responsibilities was a major deterrent to attending medical appointments, as these women experience like time conflict between household responsibilities, work schedules, and things like medical appointments. Some women with HIV positive partners reported that they got support from their partners. They helped each other with medication reminders, which actually fostered medication adherence. Now, before I conclude and talk about what next, I'd like to mention a few limitations of the study. First, the study sample was obtained from a specific geographic location, limiting the ability to generalize these results to older Black women living in other geographic settings. The other thing is that the study is also limited by recall bias. Like these women self-reported their experiences living and managing HIV. And some of them were actually infected like decades ago. So their responses might have been impeded by difficulties in recalling these memories, right? So that being said, next slide, please. So findings from this study have implications for education and clinical practice. For example, as I mentioned earlier, one benefit of disclosure was developing closeness with family and friends, which fosters support and improve the health outcomes of these women. Sometimes it really goes beyond breaking the news and how do I even tell them to, after I tell them, how are we going to cope to move forward? And these things can be addressed in family therapy. As we can all agree, HIV-related stigma is often a result of limited knowledge and awareness about the disease, as seen in this study, because some of the women actually stated that their family members were illiterate of HIV prior to their diagnosis. So something like continuous support and education about HIV and ways to manage it should be provided to patients and their families to ensure that educational background and I guess totality, everybody being on the same page. Finally, in the clinical setting, beyond antiretroviral therapy adherence, other aspects of HIV treatment engagement should be considered in the discourse of treating these patients to ensure like a successful treatment and management of HIV. One thing I'd like to note is, remember, there's more to an HIV patient than their diagnosis. So let's just be aware and take care of them holistically as healthcare providers. Thank you. Any questions?
Excellent, thank you. So everyone else can come off the mute and start your video again. So thank you, Vivian. Okay, you finished before your 6 minutes. Okay, so we have 2 minutes for questions. So everyone can put their questions into the box. So so just a little bit on the background. So I noticed that you were working with some folks from Miami. Is that right?
Yes, I'm currently in Miami.
Okay. Yeah. Oh, you're currently in Miami?
Yes.
Okay. Is that part of the rotations that you got to do?
Yes. So we finished on the island, and then I'm doing my clinical rotations with FIU.
Okay, that's excellent. And then it looks like also part of your group that you're with, it's interdisciplinary.
Yes,
it's
like the different like nursing.
Yes.
Yes.
Okay. All right. That's wonderful. That's a great group. Okay. Do we have any questions in the chat yet? Okay. So of the social determinants of health, which I know that a lot of the med schools have integrated into the curriculum a lot, among this population group, did you find which social determinants of health did you feel were most impactful in this group? Like if you had to say, identify 2 or 3 of them that you felt like were most important for this population group that you were studying?
Definitely. So I would say, based on the results that we got, the most important ones were the social and community context, and also the neighborhood and environment, which also ties into familial relationships. Because if I can recall clearly, about the mean age and the average monthly income and the years of education of these patients also played a role, because some of them didn't have the education needed before when they got infected. So they actually had to do research on their own to find out about the disease before even telling their families. Because it's one thing when you have a disease and you don't know about it, and you cannot explain it to somebody else, and you have those things that are limiting you, because even when your provider tells you something about maybe take your medication or something, you have those belief systems that are hindering you from moving forward in your treatment plans and in adhering to those advice. So that was one thing that stood out for me.
Okay, thank you so much. We're going to move on next to Albert's presentation.
Okay, thank you.
So Albert, you ready? Everyone else will go off video and mute. Okay. All right. So
could you also please present my slides?
What?
Could you also please present my slides?
Yeah, I will. I've got them. Hopefully this looks like your slides.
Looks good. Yep. Okay. So good morning, everyone. My name is Albert Holler, and I'm a second-year medical student at Johns Hopkins. I'm excited to share this research I did with Dr. Kathy Handy Marshall, and the title of my project is Differential Activities of PARP Inhibitors in BRCA1 versus BRCA2 altered metastatic castration-resistant prostate cancer. For some general background, prostate cancer is the second most frequent malignancy and cause of cancer death in the United States. And to put this prevalence into context, about 1 in 9 men will get prostate cancer in their lifetime. Initially, the treatment is androgen deprivation therapy, or ADT, which serves to block, it is a hormonal therapy that serves to block testosterone and dihydrotestosterone. And although most men respond, about 80 to 90% of men respond, most men do go on to develop progressive disease following ADT, known as castration-resistant prostate cancer. And so this is my overall poster. And on the next slide, we can zoom in on some important processes. So this is the proposed mechanism for the drug I'm studying in this study, and it's poly-ADP ribose polymerase inhibitors, or PARP inhibitors. And these kill tumor cells by a concept termed synthetic lethality, which I'll describe a bit further. So both BRCA proteins and PARP proteins play an important role in repairing DNA. So if there's a patient with mutation that causes them to reduce damaged BRCA proteins, PARP acts as a second line of defense to repair this damaged DNA. If we knock out this defense mechanism, like we can see, so if we knock out this defense mechanism in a cancer cell, the cell will not have the means to repair its DNA and replicate. And PARP inhibitors are used in the setting of patients with BRCA mutations to knock out the DNA repair mechanisms that are used by tumor cells and thus result in cancer death. So overall, the objective of this study was to determine whether the efficacy of PARP inhibitors differs between men with BRCA1 and BRCA2 mutations, and to examine the differences in other genomic alterations that coexist with BRCA1 and 2 mutations. The next slide, please. Now I'll explain the design of this study. It was a multi-center retrospective analysis of 123 patients with MCRPC from 12 different academic sites, some international, who received single agent PARP inhibitor treatment between December of 2014 and July of 2020. Only patients harboring deleterious mutations in BRCA1 and BRCA2 were included in the study, as opposed to mutations that were benign or not known to be deleterious. Demographic, clinical, genomic characteristics were included, including age, Gleason score, PSA level, stage of diagnosis, metastatic distribution, concurrent genomic alterations, and the type and number of prior systemic therapies received were collected for all patients. Our primary endpoint was the percentage of men achieving confirmed 50% decline in PSA level from baseline at the initiation of PARP inhibitor therapy, which is the PSA 50 response. Our secondary endpoints were PSA PFS, PSA progression-free survival, which is defined as the time until a 25% increase in PSA from baseline or nadir, the lowest point. PFS, progression-free survival, is defined as the time to investigate or assess clinical or radiographic progression, excluding PSA progression. And OS, overall survival, is defined as the time to death from any cause. PSA 50 response rates were compared between BRCA1 and BRCA2 altered patients using logistics regression. Time to event outcomes of PSA PFS, PFS, and OS were estimated using Kaplan-Meier method, and comparisons between the groups carried out using the Cox proportional hazards model. Next slide. So this waterfall plot on the left demonstrates that there were significantly fewer PSA 50 responses in BRCA1 altered versus BRCA2 altered MCRPC patients. The y-axis shows the percent change from baseline PSA, and each line in the x-axis represents the different individual patients. The red lines are BRCA1 patients and the blue lines are BRCA2 patients. And you can appreciate the much higher density of blue below this 50% line in the middle. Only 23% of BRCA1 patients achieved a PSA 50 response, while 63% of BRCA2 patients did, with a p-value of 0.01. And on the right is another important graph. So PSA, PFS, PFS, and OS, all three were shorter in BRCA1 versus BRCA2 altered patients. And all three of these graphs, BRCA1 patients are red and BRCA2 are the blue lines. The x-axis is the time from the start of the PARP inhibitor. And I chose to highlight just this graph here showing OS, overall survival, and you can see the curves separating, indicating a shorter time of survival, and there being no remaining living patients by around week 75 in the BRCA1 group. This graph of overall survival maintains the same pattern as the other two graphs, with a high hazard ratio of 3 and a p-value of 0.01, a significant value. Next slide. Okay. A total of 123 patients, 13 BRCA1 and 110 BRCA2 were included in this study. Age, baseline, PSA, germline mutations, Gleason scores, and type of prior systemic therapies were very similar between the groups, but where we start to see some differentiation is in the presence of metastases. And BRCA1 patients had more monoallelic and concurrent TP53 mutations. TP53 is a tumor suppressor gene, and it plays a pivotal role in the cellular response to DNA damage, and mutations are associated with poor prognosis. BRCA1 patients have more concurrent TP53 alterations and more monoallelic mutations, which might be reasons why PARP inhibitor efficacy is diminished. A monoallelic BRCA mutation means that there is still one normal copy of a BRCA gene that could be producing sufficient BRCA proteins to allow for DNA repair, making synthetic lethality less effective. Overall, we can conclude that PARP inhibitor efficacy is diminished in BRCA1 versus BRCA2 altered MCRPC, which is not due to an imbalance in germline mutations, but might be more related to more monoallelic mutations and or concurrent TP53 alterations in the BRCA1 group. An important implication from this study is that additional treatment options are needed for BRCA1 altered MCRPC patients. Thank you all for getting up early on a Saturday morning, and I'll take any questions now.
Okay, I'm going to confess that I let you go a little bit over just because I forgot to flag you at the 5-minute point. So it was slightly over 6 minutes. So we'll cut the questions a little bit short. So if you guys can come off you can make your videos active. If you have any questions, if you could put them into the chat area. If you don't mind, we'll cut the questions a little bit short just to even make a slight attempt to, we're going to go over time anyway, but thank you for that. That was a really nice presentation. Questions about the study? I'll adjust my timer so that it flags me at the 5-minute point. So I flag you at the 5-minute point for the next one. Okay. Elisa, you're up next, okay?
And yeah, if you could show my slides, that would be great.
Absolutely. That's my plan. Okay. Okay, just give me a second to bring them up. Okay, hopefully you're seeing them there. And I promise to actually remind myself at 5 minutes to let you know at 5 minutes if you're still talking at that point.
Okay, sounds good. Thank you.
The floor is yours.
All right. So hi, my name is Lisa Irk, and I'm a third-year medical student at University of Virginia School of Medicine, Inova campus. And I had the privilege of working with Dr. Ergan Cheng, Dr. Wang, and Mr. Holland on this project. So the title of this poster is Prevalence of DNA Damage Repair Gene Mutations and Characterization of Differences between de novo versus primary progressive metastatic prostate cancer. So this project is compounding on previous research done by Dr. Ergan Cheng and her group on the characterization on the differences between de novo and primary progressive metastatic disease. So metastatic prostate cancer makes up a very small portion of those diagnosed with prostate cancer and can be split into two groups, de novo and primary progressive. So de novo metastatic prostate cancer diagnosis is given when the cancer is already metastatic at presentation and initial diagnosis, whereas primary progressive disease is diagnosed when formerly localized prostate cancer progresses to metastases after being treated with initial curative intent therapy. And previous analyses have shown that worse prognoses in those with de novo metastatic disease. So our intent with this study was to determine the prevalence of DNA damage repair mutations and also characterize the phenotypic variations within these two groups. So our study was a retrospective single institution study on 31 consecutive patients diagnosed with metastatic prostate cancer. So we gathered clinical and demographic variables such as age of diagnosis, stage and Gleason score of disease, which I'll talk about later, dates of recurrence, metastasis, or therapy-resistant disease, labs such as PSA, and of course, results of genetic testing from gene panels. I think it was a panel of 85 genes you can see in the blue boxes under the methods. And I'm also going to mention a part of the results here in the lower left corner. So out of the 31 patients, only 3 actually had DNA damage repair gene mutations, with 1 being in the de novo group and 2 in the primary progressive group. Next slide, please. So for a little more background, in the Pritchard article that we cite, it was shown that DNA damage repair gene mutations can be found in up to 12% of patients. And practically speaking, this is important as PARP inhibition therapy, which Mr. Haller just spoke about, is becoming part of standard of care treatment. So we went forward with identifying differences in prevalence in these DNA damage repair gene mutations within these two groups, and also characterize the phenotypic differences. Next slide, please. So going on to results, in Table 1, you can see the characterization of our de novo patients, and in Table 2, you can see that of the primary progressive patients. So in these two groups, we looked at age of diagnosis, PSA at diagnosis. PSA stands for prostate-specific antigen, which is a tumor biomarker that is produced by prostate cancer cells, and Gleason score of the tumor. So Gleason score reflects the pathological grade of the prostate tumor and correlates with aggressiveness of the cancer, with higher being more aggressive. So in Table 3, we see the comparison between these two groups on these characteristics. And as you can see, there is no statistically significant difference between the age of diagnosis, but there was a statistically significant difference with the PSA at diagnosis, with a median of the de novo group being 352 compared to a median of 6.7 in the primary progressive. And then you can also see a statistically significant difference with the Gleason score, with the median of the de novo group being 9 compared to 7 in the primary progressive group. Next slide, please. So in this slide, we have a graph representing the time to development of castrate-resistant disease, which is the time it takes for the disease to become hormone therapy resistant, which is usually first line. So visually, there is definitely a difference, and statistically there is as well, with the upper blue curve representing the primary progressive group having a longer median time to castrate-resistant disease of 2,197 days, compared to the lower red curve representing the de novo group with a median time of 738 days. Next slide, please. So in conclusion, our findings do suggest that men with de novo metastatic prostate cancer have a more aggressive disease, as seen in the higher PSA and Gleason score, and also a shorter time to developing castrate-resistant disease. A major limitation of this study is the smaller sample size, and we were unable to demonstrate a difference in the incidence of DNA damage repair gene mutations in patients with de novo metastatic cancer compared to those with primary progressive disease. Although we were able to continue to show that the de novo group does have worse outcomes of disease. So the plan from now on is to collect more data so that we can better determine if there is a link between the aggressiveness that we've seen with the de novo prostate cancer and DNA damage repair gene mutations. Thank you.
Okay, so that was the hand waving was the 5-minute mark, so you came in under 6 minutes, just so you know. Okay. Trying to stop share. Doesn't want to stop share. Oh. Sorry, just give me a second. I just had okay, so questions, you can put them in the chat area. Great. So Albert, I thought would have a question on this, and his question was, where was the most common site of METs?
So we were looking at that, but that was not the focus of this project itself. But when I was compiling the data, I think the most common site was lymph nodes. But I think further studies, I was talking with my PI, and we would love to look at if there is a difference between the sites of metastases and whether the cancer was de novo or primary progressive. I don't know if that answers your question, but.
Yeah, thank you.
Thank you.
I just had a question, which was because of the abstract. In the abstract, I think it says in our previous analysis, as a phrase in there. Sorry, is that just because this group has done a lot of previous work in this area?
Yes, so she has done, I think she has published a paper as well, and has done a few studies on the differences, sorry about my cat, between the difference between primary progressive and de novo, but there's not that many papers and groups looking at that. So yes, that phrase was based on her work previously on these two groups, yes.
Okay, all right. Okay, so let's move on to Shannon is going to be our next speaker. All right, I'm just getting your slides ready, Shannon. Of course, okay. One second. Okay. And this should look like your slides.
Yes.
Okay. Great. Does that look okay?
Yes. Should I get started?
Yes, please.
Thank you for the opportunity to present today. My name is Shannon Mwami-Bolson, and I'm excited to share my research on leveraging big data and machine learning for clinical risk prediction in patients hospitalized with COVID-19. Next slide, please. With over 100 million infections and 2 million deaths, COVID-19 continues to be a global issue that stresses health systems worldwide. And because of the uncertainty in the clinical trajectory of patients hospitalized with COVID-19, clinicians could benefit from reliable tools to help determine which patients are at the highest risk for severe disease or death to ensure that patients are treated with the appropriate level of care. As a result, we sought to leverage big data and machine learning to develop interactive and interpretable clinical risk prediction tools that can provide dynamic predictions for progression from moderate disease to severe illness or death in patients hospitalized with COVID-19. Specifically, we use data from the COVID-19 Precision Medicine Analytics Platform Registry, which is a comprehensive data source of clinical data for patients in the Johns Hopkins Medicine System who test positive for COVID-19. And for our particular analysis, we use a subset of these patients who were hospitalized and 18 years or older. And the variables that we include in our analysis include demographics as well as time-varying vital signs and laboratory values. With these data, we applied a random forest machine learning approach adapted to handling time-varying data to predict the progression to severe illness or death, which is defined by the WHO COVID-19 score of 6 or greater, as shown in the diagrams on this slide. And next slide, please. And using this approach, we demonstrated high predictive performance for the predictions of progression to severe disease or death in patients hospitalized with COVID-19. Specifically, we characterized the performance through the discrimination and calibration of our predictions. So first, with discrimination, as you can see in the table on the left, we characterized the performance using the AUC, which is the area under the receiver operating characteristic curve. And an AUC of 0.5 corresponds to random performance, where an AUC of 1 corresponds to ideal performance. And we use multiple validation methods, which I'll be happy to discuss more if there are people who are interested. But in summary of what we found in terms of the discrimination is the AUC across the different validation methods range from about 0.8 to 0.9 for both the 1 day and 1 week risk predictions for progression to severe illness or death in patients hospitalized with COVID-19, corresponding to excellent performance. And we also evaluated the calibration where we compared the predicted probabilities of progression to severe illness or death and compare that to the actually observed probability of progression to severe illness or death. And the 45-degree black line corresponds to optimal performance. And the red line corresponds to the calibration curve for our 1-day risk predictions. And the blue line corresponds to the calibration curve for the 1-week risk prediction. And as you can see here, our calibration curves align closely with the ideal calibration curve of the 45-degree black line. And next slide, please. And since machine learning approaches are often considered black boxes for their lack of interpretability, we also created visualizations to communicate the top predictors of progression to severe illness or death in patients hospitalized with COVID-19. And as you can see in the top figures here, these correspond to vital signs. And these are colored in dark blue. The panel on the left corresponds to the top variables for the 1-day risk predictions, and the top predictors are shown for the 1-week risk predictions on the left, or on the right, sorry. And both of these plots show that the top predictors correspond to vital signs, and we can get an additional level of interpretability by plotting the relationship between the variable values and the predicted values from our algorithm. And the bottom plots show the relationship between these variables and the predicted values for the 1-day risk predictions on the left and the 1-week risk predictions on the right for some of the top variables. And as you can see here on this diagram, the SpO2 to FiO2 ratio, as it decreases, there's a sharp increase in the risk for progression to severe illness or death. And next slide, please. And seeing the potential that our work could have on patient care, the hospital leadership has been extremely enthusiastic and supportive of translating these developments to clinical care. And I'm excited to share that our risk prediction tool is now a part of Epic at Hopkins. And as an example, from these screenshots, you can see both the 1-day and 1-week risk predictions of progression to severe illness or death as added to patient lists within Epic. And additionally, you can see what factors contribute to the score. And we're also working on increasing the interpretability of these predictions by providing visualizations in the form of individually tailored summary decision trees. And as you can see here, this patient has a 57% risk of developing severe illness or death in the next week, and this decision tree traces out that logic. So overall, in summary, using the predictive power of machine learning and longitudinal data from over 3,000 patients hospitalized with COVID-19, we developed interactive tools that rapidly and accurately provide the probability of a patient's progression to severe illness or death based upon readily available clinical information in a way that can be easily integrated into the workflow of caring for patients. And thank you for this opportunity to share my research, and be happy to take questions.
Okay, great. So that was 6 minutes, and I'm not sure if it got all the way to the end, but I want to give you that flag. So everyone can come off video, and you can put any questions about that. That was great. Thank you, Shannon. Any questions about that study into chat box? I noticed the death toll was at 2 million at that point. So was that December? Was that that one?
The latest statistic was from earlier this month. So we described it as a little over 2 million. So yeah. We last updated that towards the beginning of this month, but that was the latest statistic that I included as part of the poster, which is now exceeded 2 million.
Yeah. Okay. All right. Okay, great. Do we have questions about that study? Okay, that was excellent. That was all really, really good.
All right, so for those of you I haven't already introduced myself to, good morning. My name is Thomas Gracie, and today I'd like to share with you a meta-analysis and systematic review my colleagues and I put together about the association of preoperative frailty and postoperative delirium. So I really want to start the discussion with postoperative delirium because this postoperative outcome is associated with its own morbidity, mortality apart from surgery. So people who develop postoperative delirium compared to those who don't have higher mortality, longer hospital stays, and persistent cognitive impairment even up to a year out of discharge. So this is a really important outcome that we would like to avoid, and we're looking for ways to risk stratify our patients to see if we can predict this outcome. In patients older than 65, a particularly promising avenue is frailty assessment. So specifically, a number of studies have started to suggest that patients who are older than 65 who demonstrate a frailty phenotype are at higher risk of developing postoperative delirium. However, this finding has been problematic because there's a duplication crisis in measurement of frailty and delirium. Namely, there are many tools for assessing both of these metrics, and not all of them have been validated, and not all of them are based on bedside assessment. In fact, many are based on chart review. So our aim with this study is not only to consolidate the research and synthesize it into a small subset of studies that measure both preoperative frailty and postoperative delirium rigorously, but also to look specifically at tools that can be used in a fast-paced clinical setting, such as in the perioperative setting, in the anesthesiologist's office, or even in the primary care provider's office. So let's move forward and talk about how we pared down this large body of research into a manageable subset and our inclusion and exclusion criteria that define that process. So we'll go ahead and advance to the next slide. So this is our PRISMA flow chart, and I would like to highlight a number of reasons why we excluded a number of studies either at the full text review or at the abstract stage. So apart from studies that were not relevant to the research question, the main reason we filtered out studies is, as mentioned, because the frailty assessment tool is one that's maybe only been used once in a study and never validated, or use of chart review tools that may not accurately represent the patient at the time of assessment at bedside. Other reasons we excluded studies is for similar pitfalls in delirium measurement metrics, or often because the patient's comorbidity or nature of surgery independently causes postoperative delirium. So for example, patients with a history of CVA, patients receiving intracranial neurosurgery, and patients with a history of substance use disorder, all these things can cause postoperative delirium. So we screen these populations out. So that left us with a subset of 9 high quality studies that we then proceeded with for systematic review and meta-analysis. So I'll go ahead and advance the slide. So let's define what sort of studies we're talking about here. And right now what we're looking at is the AHA cardiac risk level of our studies. So what this is it's a risk that describes the burden of comorbidity and poor outcomes using as a surrogate risk of MI as the primary driver of that category. So in other words, 6 of these studies, patients receiving these surgeries, which are almost categorically cardiovascular in nature, have a very high risk of MI. And we can use that as a surrogate to predict a number of other postoperative outcomes, including delirium. 3 of these studies, however, were based on intermediate risk procedures. So things like general abdominal surgery, arthroplasty, and spine surgery. So now that we know what sort of study population we're looking at and the sorts of tools we use to arrive at this subset of studies, let's talk about what we actually found. So I'll go ahead and advance the slide. So when we calculated a summary odds ratio across the 794 patients across these 9 studies, we found a significantly increased odds ratio of 2.1 for development of postoperative delirium in patients over the age of 65 who were defined to be frail with our measurement tools. This is critical for several reasons. One, for patients who need this surgery for life-saving purposes, obviously we may not be able to defer the surgery due to postoperative delirium risk, but we can definitely be more aggressive in our allocation of resources and our education of the team in identifying the patients that are most likely to become delirious because of their frailty status. On the flip side, if we're talking about an elective procedure such as a hernia repair or maybe certain arthroplasties, the patient may not actually benefit more from surgery because of the risk of mortality and morbidity due to postoperative delirium as predicted by their frailty status. However, there are some important limitations in this data, which we will discuss here. So I'll go ahead and move to the next slide. So the problem with studying frailty is it's not something you can randomize or blind. So most of our data come from observational work, prospective or retrospective.
1 minute.
And that is one large source of bias. Another source of bias within studies, as we determined with the Robbins Eye assessment tool of non-randomized studies, many of these studies had confounding variables, such as differences in baseline cognition or age between studies. Also, a number of studies had problems with how they selected participants retrospectively, or had missing data, or were not consistent in measurement. The bottom line is that most of this research is of moderate or serious risk of bias, which means the outcome we demonstrated as more research comes out may change in the estimate size and may perhaps even the directionality based on bias. So future directions would be to revisit this research when we have a larger amount of high quality studies, and perhaps to substratify by types of procedure, either intermediate or high cardiac risk. So that's everything I have for you guys this morning. Thanks again for having us here at the student conference, and I'm happy to take some questions.
Anybody have questions for Thomas? One thing I was knowing, Thomas, on your main poster board, you had a funnel plot, which, I love meta-analysis and all the wonderful statistical ingenious things that come along with the meta-analysis. Can you explain the funnel plot and why it was used?
Sure, no problem. And if we can back up to the poster so everyone can see the funnel plot. The long and short is the funnel plot is used to predict publication bias. So the question is, if people had studies that did not show an effect, did they choose not to publish because there's sort of an inherent bias towards publishing a significant finding? And the funnel plot is used to tease that out. What our funnel plot showed is it could not definitively demonstrate either a lack or presence of publication bias. So it fell in sort of that intermediate category where it's unclear whether or not we expect there to be unpublished work based on the directionality of the data.
Very cool. Yeah, well said. Excellent, excellent. Yeah, very important topic, obviously. We spoke about that before. Any other questions for Thomas? Very good. One last question for you, Thomas. Did you weight the different studies? Did they get a certain weight, or you kind of took them all together, the ones you ended up with in that forest plot?
There was very vigorous discussion about this point. So basically, from what we read in terms of Cochrane guidelines, it's actually not recommended to weight studies based on bias. It's something that's been discussed at some length, and that's kind of the current state of the literature, is our understanding is not to weight. But what we are hoping to do is, when more studies emerge, what we can do is a subset analysis of low and moderate quality studies. Right. We tried to do that this go around, but the N wasn't quite high enough.
Got it. Excellent, excellent. Well done. All right. That is great. So we're going to move on. Shujan will be up next. Okay.
All right.
You ready?
Yep. So good morning, everyone. I'm Srujan Kavarapu. I'm a third year at Hopkins, and our project looked at radiation exposure during vertebroplasty and kyphoplasty. Next slide, please. So percutaneous vertebroplasty, abbreviated PV, and balloon kyphoplasty, or BK, are two minimally invasive procedures used for pain relief for vertebral compression fractures. They involve cement injection into the affected vertebral body to improve its support. PV directly injects cement, while BK inserts and inflates a balloon first to stent open the space and provide more room for the cement. Now, this is performed under image guidance via fluoroscopy, and as such, radiation exposure is a concern. However, that exposure is very poorly characterized in the literature for two reasons: significant data heterogeneity and a lack of standardization of values, which is something we addressed in our methods. Our objective was to systematically review the available literature to clarify what the true exposure might be. So what did we do? We queried 5 databases using the Covidence platform to organize the review via PRISMA guidelines. Over on the figure on the right, we started with 1,600 records, removed duplicates, and screened abstracts for relevance. 80 full texts were reviewed with exclusion criteria in the bottom right, and 27 studies were finally included in the review. Exposure estimates were provided via radiation dosimeters placed on the operator or patient, and there were 3 main ways we standardized the values to allow for these comparisons. The first way is that we standardized all values by the number of vertebrae treated. The second way is that all dose estimates were converted to millirems. There's a lot of units in the literature, such as millirems, rems, sieverts, grays, so we put them all into millirems. And the third way is that numbers needed to harm, or NNH, were calculated via annual occupational safety dose limits per organ given by two regulatory commissions, the USNRC and the ICRP. Next slide, please. So here are the results for operator exposure. All four tables here are organized similarly and are stratified by the usage of protective equipment or not, which can include lead-lined goggles, a thyroid shield, a lead apron, lead-lined gloves. We looked at the time it took to do the procedure overall, the fluoroscopy time, and radiation doses measured at the eye, neck, torso, and hand were available with their corresponding NNH estimates beside them. Now, there are a lot of numbers here, and we ran a bunch of statistics comparing between and among all the groups that I'll show in a couple slides, but I wanted to point out a key finding here in the protected conditions down below. Looking across the various body parts, exposure at the hand was the limiting factor for both procedures because the NNH estimate was the lowest for the hands. For example, the hand estimate was 524 for PV and 266 for BK. Next slide, please. And these are the results for patient exposure. So radiation exposure was recorded in 4 different ways. Some were direct measurements, such as a dosimeter placed on the patient's flank or an entrance skin dose. Or there were indirect measurements via dose area products or effective doses calculated from the fluoroscopy settings. For 3 of these measurements, PV actually had lower exposure, but BK actually had lower exposure for a calculated effective dose. So making an overall conclusion for this comparison is a little bit tougher, but given that both of the direct measurements point towards PV having lower exposure and this being consistent with the operator exposure, as I'll show on the next slide, it seems most consistent and convincing that PV does have lower exposure than BK. Next, please. So for comparative statistics, these were performed via independent samples t-tests. Protection decreased exposure for both procedures. There was a sort of a sanity check, making sure that this heterogeneous data does have validity, and it does. PV had lower exposure than BK for both the unprotected as well as the protected conditions. And PV also had shorter procedure and fluoroscopy time, which can partially explain the lower exposure. BK is a little more complicated, takes a little extra time to inflate the balloon, so can explain a little bit more of the extra fluoroscopy time. And for patient exposure, though the results were a little contingent on the means of assessment, PV in general had lower exposure than BK. So what does this all mean? Well, radiation protection is effective for these procedures, so we can continue to recommend appropriate radiation protection measures. BK has greater operator exposure, and this effect persists even with the use of protective equipment. And BK can also result in greater patient exposure. So a combination of these factors can help influence interventionalists in terms of choosing between PV and BK. Fortunately, the NNH for these procedures is relatively high at 524 and 266 treated vertebra for both PV and BK. Only busy proceduralists might hit these numbers, or proceduralists that perform other procedures with radiation exposure might be at a cumulative risk of exceeding safe limits annually as well. Overall, though, we hope that our project helps interventionalists be more cognizant about radiation exposure, helping them to make decisions between PV and BK using intermittent or pulsed fluoroscopy versus continuous fluoroscopy, as well as help them to adapt to newer technologies on the horizon that might have lower radiation exposure, such as guidance systems using augmented reality, laser navigation, computer navigation, and CT guidance. So some exciting stuff that is becoming a little more increasingly common. So in terms of future directions, comparing the radiation exposure between these newer modalities and newer devices to conventional fluoroscopy remains a target for future investigation. Thank you. I'm happy to take any questions.
Shujan, thank you. Excellent. Excellent work. Any questions for Shujan? I know he asked several before, and again, what I was interested before is, the time it takes to do these individual procedures, and of course BK seems to take a little longer. It's why the number needed to harm may be lower. And how many procedures would this kind of equate to on average, would you say? Like, to hit that 266 mark or that 524, did you work out like how many procedures annually procedures would do to kind of hit that mark?
That's a great question. I can go heuristically based off what I looked at the data in terms of how many vertebra were treated during a procedure. It was usually between 1 to 2. So if I had to put a number on it, I'd say like 1.5, because there were some procedures that went up to 3 or 4 vertebrae as well.
I see. And that would take more time, obviously, if they're doing multiple levels.
And then that was a big reason that we went by doing it by organizing all the data values by number of vertebra. A lot of studies out there did it by number of patients, but we think that that's a little disingenuous in terms of what it actually entails.
Indeed, indeed, indeed. So the theme is cover the hands.
Absolutely.
Very good, very good. Any other questions out there? Fantastic. Sujan, thank you once more. And I'm going to stop sharing. April, I'm going to let you share.
Okay, I'm going to ask if Matthew could still do the timing for the presenters that I'm going to share the screen for.
That's fine.
Okay, all right. All right, so first we're going to have Albert go. Oh, sorry, I think how does that look, Albert?
Looks great, thank you. Okay, I'll get started. So my name is Albert Holler, and I'm a second-year medical student at Hopkins, and I'm really excited to share the research I did with Dr. Kathy Handy Marshall. For some general background, prostate cancer is the second most frequent malignancy and cause of cancer death in the United States. And to put those numbers into context, about 1 in 9 men will develop prostate cancer during their lifetime. Androgen deprivation therapy, or ADT, is usually the initial treatment for prostate cancer, and those success rates are, the initial response rates are around 80 to 90%. Most men do progress to develop castration-resistant prostate cancer. Now we can zoom in on some important parts of this project. Next slide, please. So the proposed mechanism behind this drug, poly-ADP ribose polymerase inhibitors, or PARP inhibitors, as I'll say from now on, they kill tumor cells by a concept termed synthetic lethality, which I'll explain a bit further. Both BRCA proteins and PARP proteins play an important role in repairing DNA breaks. If there is a patient with a mutation that causes them to produce damaged BRCA proteins, and in the second graphic we can see in the cancer cell, PARP acts as the second line of defense to repair the damaged DNA. So if we knock out this defense mechanism in a cancer cell, this cell will not have the means to repair its DNA and replicate. And PARP inhibitors can be used in the setting of patients with BRCA mutations to knock out DNA repair mechanisms that are used by cancer cells and thus result in cancer cell death. Overall, the objective of the study was to determine whether the efficacy of PARP inhibitors differs between men with BRCA1 and BRCA2 mutations, and to examine the differences in other genomic alterations that coexist with these mutations. Next slide, please. Now I'll explain the design of the study. It was a multi-center retrospective analysis of 123 patients from 12 academic sites, some international, who received single-agent PARP inhibitor treatment between December of 2014 and July of 2020. Only patients harboring deleterious mutations in BRCA1 and BRCA2 were included in the study, as opposed to mutations that were benign or not known to be deleterious. A lot of different factors were included, including demographic, clinical, and genomic characteristics, including age, Gleason score, PSA level, stage of diagnosis, metastatic distribution, concurrent genomic alterations, and the type and number of prior systemic therapies received. The primary efficacy endpoint was the percentage of men achieving a 50% decline in PSA level from baseline at the initiation of PARP inhibitor treatment, which is the PSA 50 response. Secondary endpoints were PSA PFS, defined as the time until a 25% increase in PSA from baseline or nadir, the lowest point. PFS is defined as the time to investigator assess clinical or radiographic progression, excluding PSA progression, and OS is the time to death from any cause. PSA 50 response rates were compared between BRCA1 and BRCA2 alter patients using logistics regression. The time to event outcomes of PSA PFS, PFS, and OS were estimated using Kaplan-Meier method, and comparisons between groups were carried out using the Cox proportional hazards model. Can you move to the next slide, please? So on the graph on the left, this waterfall plot demonstrates there is significantly fewer PSA 50 responses in BRCA1 altered versus BRCA2 altered MCRPC patients. The y-axis shows the percent change from baseline PSA, and each line in the x-axis represents a different individual patient. The red lines are the BRCA1 patients, and the blue lines are the BRCA2 patients. And you can appreciate the much higher density of blue below the 50% line. You can see horizontally. Only 23% of BRCA1 patients achieved a PSA 50 response, while 63% of BRCA2 patients did, with a p-value of 0.01. Now on the right, PSA, PFS, PFS, and OS were shorter in BRCA1 versus BRCA2 patients. Across the board, all three were shorter. In all three of these graphs, BRCA1 patients are red and BRCA2 are the blue lines. The x-axis is the time from the start of the PARP inhibitor, and I chose to highlight this graph showing OS, and you can see the curves separating, indicating a shorter time of survival, and there being no remaining living patients around 75 weeks in the BRCA1 group. The graph of OS maintains the same pattern as the graphs of PSA, PFS, and PFS, with a high hazard ratio of 3 and a p-value of 0.01, a significant value. And can you move on to the last slide? So looking at our results in a table format, a total of 123 patients were included. Age, baseline, PSA, germline mutations, Gleason scores, and types of prior systemic therapies were similar between the groups, but where we start to see some differentiation is in the presence of metastases, and BRCA1 patients had more monoallelic and concurrent TP53 mutations. TP53 is a tumor suppressor gene and plays a pivotal role in cellular response to DNA damage. These mutations are associated with poor prognosis. BRCA1 patients have more concurrent TP53 alterations and more monoallelic mutations, which might be reasons why PARP inhibitor efficacy is diminished. A monoallelic BRCA mutation means there's still one normal copy of a BRCA gene that could be producing sufficient BRCA proteins to allow for DNA repair, making synthetic lethality less effective. Overall, we can conclude that PARP inhibitor efficacy is diminished in BRCA1 versus BRCA2 altered MCRPC, and this is not due to imbalance in germline mutations, but might be more related to monoallelic and or concurrent TP53 mutations. An important implication from this study is that additional treatment options are needed for BRCA1 patients. Thank you all for listening, and I'll take any questions.
Yeah, fantastic, Albert. Yeah, that was very impressive. So now currently for prostate cancer, the PARP inhibitors are, I haven't seen a part of the algorithm. Can you tell me where this would fit into the algorithm as you see it in the future for prostate cancer treatment?
So the PARP inhibitors were just recently accepted by the FDA in May of 2020. So it's not been around for very much. But I see them immediately after failure of ADT, moving directly to PARP inhibitor treatment for at least metastatic castration-resistant prostate cancer.
That's where I think it's going to fit too. Yeah, so second line treatment after androgen deprivation therapy. Yeah. Yeah, maybe as an add-on, perhaps even if. So, are we going to move towards testing for BRCA in prostate cancer patients? I know this is one area where genetic testing has been slow in prostate cancer.
That's a good question. I don't know enough about, well, and in terms of this type of cancer, about 10 to 20% of patients harbor some sort of homologous recombination defect. So I'd have to look at more stats on how effective actually screening for BRCA initially would be.
Right. Excellent. Thank you. Yeah, the future.
Thank you.
Thank you.
Okay, so are we ready for our next person?
I think so.
Okay, that'll be Shannon. Okay, Shannon, I think we have yours here.
Great, thank you. Thank you for the opportunity to present today. My name is Shannon Wongwu-Bolson, and I'm excited to share my research on leveraging big data and machine learning for clinical risk prediction in patients hospitalized with COVID-19. Now, with over 110 million infections and over 2.5 million deaths, COVID-19 continues to be a global issue that stresses health systems worldwide. And if you could move on to the next slide, please. Because of the uncertainty in clinical trajectories of patients hospitalized with COVID-19, clinicians could benefit from reliable tools to help determine which patients are at the highest risk for severe disease or death to ensure that patients are treated with the appropriate level of care. As a result, we sought to leverage big data and machine learning to develop interactive and interpretable clinical risk prediction tools that can provide dynamic predictions for progression from moderate disease to severe illness or death in patients hospitalized with COVID-19. Specifically, we use data from the COVID-19 Precision Medicine Analytics Platform Registry, which is a comprehensive data source of clinical data for patients in the Johns Hopkins Medicine System who test positive for COVID-19. And for our particular analysis, we use a subset of these patients who were hospitalized and aged 18 years or older. The variables in our analysis included demographics as well as time-varying vital signs and laboratory values. With these data, we applied a random forest machine learning approach adapted to handling time-varying data to predict the progression to severe illness or death, which was defined by the WHO COVID-19 score of 6 or greater, as shown in the diagram on this slide. And if you can move on to the next slide, please. Using this approach, we demonstrated high predictive performance of the predictions from our algorithm for the progression to severe disease or death in patients hospitalized with COVID-19. In particular, we evaluated both the discrimination and the calibration of our approach. And for the discrimination, we evaluated the performance using the area under the receiver operating characteristic curve, or AUC, where an AUC of 0.5 corresponds to random performance and an AUC of 1 corresponds to ideal performance. And we performed various ways for validation, and across all the different validation approaches, which I'd be happy to discuss in more detail as well. But as a quick summary from this table, you can see that the AUC ranges from about 0.8 to 0.9 across both the 1-day risk predictions and 1-week risk predictions, corresponding to high predictive performance across the multiple validation methods. And in addition, we evaluated the calibration, where in the curve, you can see the ideal performance would be the 45-degree black line, where the predicted performance of the probability for the risk corresponds to the observed probability for the progression to severe illness or death. And in red, we showed the calibration curve for the 1-day risk predictions, and the blue corresponds to the 1-week risk prediction calibration curve. And you can see here the calibration is excellent for both the 1-day and 1-week risk predictions. And next slide, please. And since machine learning approaches are often considered black boxes for their lack of interpretability, we created visualizations to communicate the top predictors for progression to severe illness or death in patients hospitalized with COVID-19. And as shown in the diagrams on the top, for both the 1-day and 1-week risk predictions, the most informative variables are related to vital signs, displayed here in dark blue. And for additional insights, as shown in the bottom figures, we can also plot the relationship between the value of the variable and the predicted risk. For example, for the SpO2 to FiO2 ratio, as the value decreases, there's a sharp increase in the predicted risk of progression to severe illness or death. And seeing the potential that our work could have on patient care, the hospital leadership has been extremely enthusiastic and supportive of translating these developments to clinical care. Next slide, please. We received an enormous amount of support to get this tool into the hands of clinicians, and I'm excited to share that our risk prediction tool is now part of Epic at Hopkins. For example, the risk predictions for both the 1-day and 1-week risk of severe illness or dying can be added to patient lists within Epic. And additionally, you can see what factors contribute to the predicted score. And we're working on increasing the interpretability of these predictions in the form of individually tailored summary decision trees, where you can see the prediction logic, which is tailored based upon the particular patient. So for instance, for this patient who has a 57% risk of developing severe illness or death in the next week, the branches of the decision tree corresponding to that particular patient is highlighted is at the prediction logic to that 57% risk. So overall, what I've shown today is that using the predictive power of machine learning and longitudinal data from over 3,000 patients hospitalized with COVID-19, we're able to develop interactive tools that rapidly and accurately provide the probability of an individual patient's progression to severe illness or death based upon readily available clinical information in a way that can be easily integrated to the clinical workflow of caring for patients. And thank you again for this opportunity. I'd be happy to take questions.
Shannon, that's cool stuff. That's cool stuff. We're doing something. I got a few questions for you here. It's big data. What was, and this was a retrospective database, right? Initially that you built this off of. How big was the database?
So for the database that we use, we initially had over 3,000 patients, and the database originally was about 3,500 patients that we're looking at for our initial cohort. And in the inclusion and exclusion criteria, we're also considering that we wanted to only look at adult patients and then also exclude patients who developed severe illness or death within the first 6 hours of hospitalization, since we didn't want to include patients who were already severely ill or had passed away in their initial presentation to the hospital. So we were left with 3,163 patients for our analysis for developing the predictive tool that I was discussing.
Gotcha. And this data that you're collecting was from the initial vital signs from the emergency room? And is that where this?
So it does include data within the ED as well. We included data that was time varying in nature. So in contrast to predictive algorithms and other analyses that have been presented in the literature in the past, those have been primarily based upon baseline variables. So what you're mentioning of data within the ED or upon initial presentation. What's unique about our approach is that we not only include those data points, but we also include time varying data points as well. So as we collect more information, as the patient is hospitalized longer, we learn more about the patients and we continuously have additional information. And with our approach of using time varying covariates, we're able to not only include the baseline information, but each time point, we are able to incorporate additional information that's gathered and integrated into the record as well.
So the physician gets real-time updated risk stratification, I would, on Epic. That's
right.
Pretty cool.
Thank you.
Yeah, very cool. Are you going to study this prospectively to see how it pans out?
Yes, thank you for that question. So in the last slide that I was showing the Epic tool, we're now working on collecting data on the predictions and how that corresponds to the actual patient's progression in the hospitalization. Some of our preliminary work now has been showing and evaluating the discrimination in terms of the AUC and the calibration shows that overall this work is performing very well. We're also hoping to be able to gather that information to continuously update the tool over time as well, so that we make sure that our algorithm is trained on the most complete data that we can have.
It would be very cool to have two groups, right? One group of physicians that get this information and one group that doesn't, right? And that would
right. Right. Yeah, that's a great idea. And that was something that we were discussing a lot before as well. We wanted to do a randomized trial where doing the exact thing that you were mentioning, if some physicians having this tool and some not. But with that approach, we weren't able to get everything implemented in the way that we wanted to do that exact study. So we're planning to do something similar in terms of evaluating it. And we might, in future iterations, do that exact study that you were mentioning as well. I think that's a great idea. And thank you for mentioning that.
Cool. Very good. I see the good Dr. Brian Girbaldi is on this study here. Very good. Very good. Excellent.
Thank you.
Thank you. All right. I think if that's ending us up, I guess what we'll do is have the students go back to the main room and the judges will stay behind and we'll make our final choices. You guys were all outstanding, just absolutely outstanding. Thank you.
Agreed. Great job, everybody.
Thank you.
Thank you very much.